Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and today we are with Professor Jammu from India, and he's a well-known bariatric surgeon. And no doubt, Professor is always sportive, always. So anytime when we invite, and it's honor because I remember his last session in MGB, OAGB. That was the one of the best interview session, very fruitful and definite. Tonight it will be again one of the best session. My viewers, as you know, we have completed our 4 interview series. Every interview series was for 6 months. We have started with MGB, OAGB, then continue with safe sleeve gastrectomy, then Roux-en-Y gastric bypass, then metabolic surgery in low BMI, and now we are going on revisional bariatric surgery. That is the most important nowadays, because if we see nowadays we are facing more revisional bariatric surgery, but still there is no standard guideline. This is the time to talk more about revisional bariatric surgery, and I will try my best to invite someone who are expert of this revisional, and one of them is Professor Jammu. Sir, please, over to you.
Thank you, Dr. Abbas, for the nice introduction. Yes, as you said that I was in your last session on MGB, and now the time has also come that patients are coming to us for the revision surgeries. So there was time when we were doing sleeve revisions, and there was time, when we were doing this band revisions. Now we are doing sleeve revisions, and now even some gastric bypass revisions, some reversals, and with other problems coming in. So let's go ahead with the discussion.
Yeah, sir, so much thanks. Sir, as you know, so we have repeated questions, and I will ask question and we will discuss about specific question, because we are live also on Facebook group, Global Laparoscopy, and we will also take some question from our viewers, and then we will go ahead. Sir, personally I know, but for my viewers, so your brief introduction and especially your experience in revisional bariatric surgery.
Okay. Dr. Abbas, myself, Dr. G.S. Jammu. So I'm into bariatric surgery since 2007, and I from India, Punjab, state of Punjab, in Jalandhar city. I started my practice in 2007 with the Roux-en-Y gastric bypass and sleeve surgeries. Later on, we switched our practice mainly to the mini gastric bypass surgery, and I've been attending national and international conferences as a faculty member. I have publications and book chapters on mini gastric bypass, some publications in India journals, as well as high index obesity surgery journals on mini gastric bypass, sleeve gastrectomy, and Roux-en-Y gastric bypass.
Sir, so much thanks. Sir, so now because our topic is today's revisional bariatric surgery, I am interested to hear from your side definition of so revisional, this is conversion or this is correction. How you define when you are going to do a revisional bariatric surgery? How you define?
Dr. Abbas, when we talk of revisions, it comes all conversions, and it also involves corrections. It also involves reversals. So when we are discussing revision surgery, it involves all these 3 disciplines. So the indications of correction may be different from the conversion and from the reversal. So if we talk of correcting the procedure, that is when we need to correct a performed bariatric procedure, that is like when we are performing some sleeve gastrectomy procedure and the patient starts regaining weight, and there's pouch dilatation, and we have to reduce the size of the pouch, or in case of mini gastric bypass, or in case of Roux-en-Y gastric bypass, when there's a dilatation of the stoma size, the patient can regain some lost weight. Then we performed a corrective surgery on that patient. And the converting one procedure to another procedure is like converting lap band into sleeve gastrectomy, or sleeve gastrectomy into Roux-en-Y gastric bypass, or converting sleeve gastrectomy into mini gastric bypass because of the weight regain issues, for the less of excess weight loss and other things. And then is a reversal of the procedure sometimes is done when there are so many nutritional deficiencies occurring due to any procedure, and patient is having complications in the form of dumping, uncontrolled diarrhea, severe hypolipidemia. In spite of all the nutritional support we give, and patient is not doing well, in order to save their life, we have to convert back or reverse them into the same anatomical stage. Then we call it reversals. So revision will involve the corrective procedures, the converting procedures, as well as the reversal procedures.
Sir, so much thanks, sir. Always we hear about failure of bariatric surgery in different international conferences, many topics and different international platform. We hear sometimes this was a failure, this was a failure. How you define this failure? Because sometimes this failure is a definition from the surgeon, or this is the definition from the patient, because the patient has some expectation. When patient consult to me at my clinic, what is the expectation of patient at that stage? So expectation is losing weight, expectation is so recovery
Yes.
of that comorbidities, and so patient to patient differs. And again, this is not only role of surgery. So again, if patient, we did a standard bariatric surgery, but unfortunately patient will not follow for that. So this that completely he will not follow. So then what will happen? So definitely then he will not achieve, or she will not achieve that target. How you define this failure, and how can we also, in my opinion, control this failure as the point of patient view and also as well as surgeon?
Yes, very good question, Dr. Abbas. How we define failure? Well, there I would say there are two perspectives. One is from patients, one is from the surgeon's perspective. So, like patients coming into the for the surgery, the main consideration, as you are saying, is the weight loss. They want to lose maximum weight loss, but sometimes they are not aware of the consequences of the excessive weight loss, which we see in daily practice. The excessive weight loss will lead to so many other complications. And if we define surgically or from the surgeon's point of view, we have seen in all our textbooks and the journals that anything weight loss, excess weight loss, than 50% of the EWL label is labeled as failure of the surgery. So anything less than that is a failure of surgery from the surgeon's point of view. But most of the patients, even if 50% of the excess weight loss is not sufficient for them, they're not happy with that. They want to lose more weight for that. So going by the science, going by the bariatric literature, the textbook literature, we say that any weight loss which is less than 50% of the excess weight loss is termed as failure of the procedure. Now, different procedures, we know that they have different failure rates, like lab band, because the incidence is decreasing because it had more failure rates, almost 30%. Then the other procedure like sleeve gastrectomy has failure rate of about 20%. Roux-en-Y gastric bypass also has a failure rate of about 20%. Mini gastric bypass again has failure rate, but not of 30 or 20%, though we do not have a published data on yet, but I suppose it is less than 20%. So all the procedures, they have their own limitations. There's no ideal procedure, but the definition is anything less than 50% is labeled as failure of the procedure.
Sir, because at our channel and also at our Facebook group, we also have some youngsters, because they are following. This is especially for our youngsters. One thing that personally this is my feeling, when patient consult to us, so patient also, my weight must be like this, okay? And we also promise to patient, yes, yes, you will achieve this one. So we never talk with them. So this exact definition, if you achieve this 50% plus excess body weight, when you will lose this is okay. And if you see you are using now insulin, and now then you are not using insulin and just you are using tablets, and your HbA1c is now less than like this number, it's also another achievement. If you don't have this knee pain, if you can go upstairs without any dyspnea, unfortunately, So the main target is weight loss. So patient also, I must be 70, and surgeon also, okay, you will be. So again, in my opinion, this public awareness is very important. Are you agree?
Yes, sure. Uh, because it depends upon the age of group of patient you're getting. So youngsters, they want to lose more weight because they want to socially, they want to look more good and presentable. That is their main concern. But for middle age and advanced age, they have other problems like diabetes and high blood pressure, dyslipidemia. So I would suggest to all my patients that you should go after quality of life, because if you're diabetic, your dose of insulin or other diabetic medicines, they reduce, your statins they reduce, your blood pressure medicines they reduce, you're able to walk, you're able to climb the stairs, so you're able to perform activities on your own, so that is independence, you are not dependent on anyone. So yes, you are right, we need to be more careful, we need to be more counsel our patient in such a way that weight loss, yes, it will occur, but don't expect miracles. It gives miracles to few set of patients, not to everyone, but yes, it can give you better quality of life. This should be the main point put forward to all the patients.
Yeah. Sir, thank you. Sir, you are, because as I know, you are doing routinely this revisional bariatric surgery. Which percentage of your total bariatric surgery belongs to revisional bariatric surgery? How much you are doing?
Uh, Dr. Abbas, out of my series of about 4,500 cases, not many I have done, but I would say about I have data of about 170 odd cases which I have revised. The cohort of patients would consist of some of my own patients and some referred to us. And like we were discussing, the indications of the revision were mostly the weight regain. And yes, we have done some reversal cases also. So the maximum number of cases would fit into category of lab band, which we have revised to sleeve or mini gastric bypass, and cases of weight regain of sleeve gastrectomy, which we have revised to again mini gastric bypass or Roux-en-Y gastric bypass. So about if you call in percentage, I say about 7 to 8% patients, they have started coming in after this decades of practice. They are coming in for the revisions now, and we are getting more and more referrals from the other hospitals for the revision surgery as well.
Okay, sir. Thank you. Sir, because now, as you mentioned about 170, 180, so you did, this is a big number for revisional surgeries, and also the most common was band to other surgeries. So what's my question now? What is the technical consideration of this revisional bariatric surgery? Because there is a thick tissue, there is a lot of adhesions. If someone is going to do this revisional bariatric surgery, how he himself prepare for such a situation? Maybe there will be a lot of adhesions with the left lobe. This is not initial surgery, and also he can face bleeding, and also which stapler he must use, and this tissue and everything. We are interested to hear more about this.
Okay. So from the surgeon's perspective, I would say the revision surgery should be planned and should be done in a center which is well equipped, which has all the armamentarium. Uh, I mean, for the advanced bariatric procedures, and you should have a multidisciplinary team available with you, and also, of course, all the intensive care unit team, the intensivists should be there. And you should not think that like a virgin plane that you will go and come out easily, perform your procedure. Yes, you expect so many adhesions. So it's not a very easy thing to do that. The complication rate is certainly more in this secondary surgery of revision surgery. It will take more time. The hospital stay is going to increase. Even the cost to the hospital or the patient will increase. So what we should be prepared on all these aspects. So if you have enough experience, yes, one can go alone. And if you have less experience, you should always have another experienced bariatric surgeon alongside with you when you're performing a procedure, because you are not sure what procedure you have to go and perform in the revision. So maybe you have to perform Roux-en-Y, maybe you have to perform mini gastric bypass, maybe you have to perform SADI, and maybe some other thing. And you have to be prepared that the chances of leak after any revision surgery are much, much more. So you have to be extra vigilant in all these cases. You cannot discharge your patient like in a daycare surgery in 24 or 48 hours. You should minimum keep all these revision cases for 72 hours in your hospital, and if the patient is good to go, then you can discharge. Patients sometimes need to stay even more. And again, as pointed out, not only leak, the chances of this bleeding during the revision surgery, and if by chance the patient is a case of ventral hernia repair and there's mesh fixation somehow, it will can make the life of the surgeon very, very tough and very challenging cases. I've seen the mesh attached to all these gastric remnants, all the stomas, all the intestines, and it's really difficult to run the bowel, and the chances of injury to bowel increase further when the patient has undergone ventral hernia surgery with the mesh placement. Sure, you should be prepared with all your team when you go for all these procedures.
Sir, excellent. Sir, one of the issue nowadays, and if we see the most common revisional bariatric surgery, as you have mentioned earlier, is weight regain after a sleeve gastrectomy, because we are now less facing gastric banding. Because yes, I remember, so last decade, yes, we have faced many revisional gastric banding, and I remember 2 decades before, yes, this was the initial most common initial bariatric surgery. One of the most common was gastric banding. Then, so just 10 years ago, it was one of the most common revisional barrier. Nowadays, we are facing a sleeve. So, what is my question? This question has two parts. Patient with insufficient weight loss, because already we have defined, so 50% less than 50% excess weight loss, so you have not achieved that target. So now just imagine patient just 30-40% lose weight, now 6-7 months, then stuck. So now 1 year. So after surgery, 4 months, 6 months, weight, no, there is stop, and now starting to gain weight. So you did some evolution, something. So like you did upper GI or some X-ray. Yes, that was not standard sleeve. That was a dilated pouch. That was that remnant of fundus there. When you will go for surgical intervention, and patient is also insistent to do surgery, still 8 months, 9 months to initial surgery, when you will decide to go, in this case there is not standard sleeve, will you go for some medication or no, you will go for surgery?
Yes, when patient there's a plateau of the weight loss is reached soon and patient doesn't lose weight, further weight. Yes, we have to evaluate the patient, and as you said, maybe it was not an ideal sleeve, it was dilated sleeve, maybe there's fundus left inside. So I would, in my practice, I will not go immediately in 7 or 8 months. I will not go into for this. Uh, Firstly, I would like to counsel my patients, do their behavioral counseling, the lifestyle changes. I will ask my nutritionist, like my psychologist, to study the patient well and counsel them about their diet. So minimum, I would wait for 18 months of my primary procedure. I will not be tempted to go before 18 months. That means 1.5 years to further do any surgery. And after 1.5 years, in spite of all these lifestyle changes and all these nutritional changes and intense nutritional support to the patient, and they have added some exercise regime, still the patient is not losing weight. And on the radiological investigations, we find that there is some fundus left or there's something that dilated sleeve. Yes, then we can go inside and perform the procedure. Sometimes patient even develop de novo reflex, as you know, in sleep patients. That also calls for the revision surgery. So my choice is that we should not go after 8 or 9 months of the failed first surgery. We should be doing some counseling and nutrition. Now we have very good medicines, as you know, available. like semaglutide orally, which is available, and even injectable is available in some countries. So we can always go ahead with this pharmacotherapy combined with that as well. And if patients are not responding, then maybe a 1.5 year, we can think of revising our sleeve surgeries to some other procedures, or re-sleeving them, or converting them into the bypass procedure, but not immediately, like 7 or 8 months.
Sir, excellent. Sir, now we can also divide this how we deal with these patients. One is MDT and also medical therapy. In these cases, are this following healthy lifestyle, and now we must accept endoscopic role. That is no doubt,
Yes.
and now it is growing and growing, because we are scientists. We must, we are, yes, surgeon, but we are now witness the role of endoscopic bariatric surgery. And last one is surgical intervention in case of. So are you agree? So in this specific case, there is a dilated this sleeve, and that was not standard sleeve. So next step, can we go for endoscopic? And then, okay, when no response, because there is no GERD, patient is just weight, stuck the weight, and now starting weight gain. And we must remember that is not standard sleeve, because sometime a junior did in any other, and now they refer to you for this case. And you see, yes, there is like half stomach is there still.
Yes, I would suggest that ESG, which has come a new tool to the aid of bariatric surgery patients, yes, we can do that. And endoscopy sleeve gastroplasty is doing a wonderful job. I would say that it's not as good as the laparoscopic sleeve gastrectomy. The results may not be same. Yes, but if we add ESG to the some failed primary sleeve, yes, it can give us better results along with some medical treatment like pharmacotherapy. It can give us some good results. And the best part is that doing re-sleeve or converting sleeve to other procedures has more complications than doing ESG, because ESG is comparatively, I would say, leak-proof procedure. The chances of leaking are less. The chances of complications are less. The hospital stay less. Patient can go home same day or the very next day, as compared to the other laparoscopic conversions or doing re-sleeve other procedures. Yes, endoscopy has come in a big way for the help of bariatric surgery, the surgeons as well as for the patients.
Thank you, sir. Sir, sometime we face, so you did, personally, you did a sleeve gastrectomy. That was standard sleeve gastrectomy. This is not from referral case from other person, but patient will not respond. So you will see, yes, the patient selection was okay. Patient was not grazer. Patient was not so eating like sweet. Everything, yes, you see, yes, this is the a perfect candidate for sleeve gastrectomy. You did standard sleeve gastrectomy, again stuck. So that was insufficient weight loss. So you will follow same thing till 18 months, and if need to go for surgical intervention, as earlier you mentioned, after 18 months you will decide to go for surgical intervention. Am I correct?
Uh, Yes, look, Dr. Abbas, sometimes, like even after performing a very ideal sleeveless gastrectomy, the patient has failed that one. We cannot cannot be very guaranteeable that patient will not fail the other procedure. So performing secondary surgery after one failed bariatric surgery procedure, we have to think twice before giving help to the patients, because after one failed surgery, the chances are the second surgery might also fail. So even in that case, I would not be tempted to go before 1.5 year of the primary surgery. And again, my emphasis would be on pharmacotherapy plus the lifestyle changes. And if that failed, then I would go for the secondary or the revision surgery in these patients.
Sir, thank you. Sir, another issue in sleeve gastrectomy is GERD after a sleeve. And there is no doubt we are facing a lot, because maybe that is due to patient selection, that is also not going to standard sleeve gastrectomy. I am not talking about this, but we are facing this. that is reality, and patient is suffering with intractable GERD. So you are using PPI, medicine, medication, diet, but no response. So when you will decide to go surgical intervention, and now patient weight about BMI is 23, 24, BMI is now standard BMI, that is the in normal range. So when you will go for surgical intervention, and which type is, according to your experience, is better to go for in this case? And also I must highlight, okay, first we will go this, then I will ask next question.
Okay. So if the patient has reached normal BMI level and patient is having some GERD problem due to sleeve or de novo reflux, then I would suggest that we should convert this patient either into Roux-en-Y gastric bypass or mini gastric bypass. Because having intractable reflux and the best treatment is converting into the Roux-en-Y gastric bypass procedure, because I have seen patients in my practice who were not having intractable GERD, and we have converted them into a Roux procedure. They have responded well to the procedure. And of course, there will be some weight loss if we add element of malabsorption to it. So we should also be prepared. In spite of if your patient is normal BMI, there will be further weight loss when you add a dose of malabsorption to this restrictive element of sleeve as well. So patients who do not respond to PPIs and there is intractable reflux, or even say patients are not tolerating some types of foods, I would suggest that converting them into a Roux-en-Y or MGB can help these patients to that can stop some reflux. And if we find in the surgery that there's large hiatus and there's residual fundus, we need to take that as well. We need to repair that as well along with the surgery.
Sir, this is, we understand this. So if there is a sleeve migration or there is a hiatal hernia, yes, we must reduce that herniated sleeve, and also we must do hiatoplasty. It's okay. But my question, I am also doing, my main practice is OAGB. But my question, this case
Yes.
is intractable GERD after a sleeve gastrectomy. Yes, there may be some migration of a sleeve, and also some hiatus. Definite there will be hiatus failure, because when we have such a restrictive procedure, definite there will be some hiatus failure. Patient BMI is normal BMI. So have you any experience to change such a case to MGB, and what will be BP limb in this case?
So if the patient has reached his or her normal BMI, we should not be doing the longer bypass. Even a small mini gastric or OAGB bypass of the length of 150 centimeter or even less than that will settle down the reflux. And if the patient's BMI is not reached, it is still a high BMI, you can increase the length of your bypass to more than 150 centimeter, and sometimes even 200 or 250 centimeters has also been performed in my practice to achieve the ideal BMI of the patient. So if you use in the series when the BMI is already reached 150 centimeter or slightly less than is sufficient to overcome this reflux problem.
Sir, again, another question. So if we see we are doing this intractable GERD after a sleeve gastrectomy, but there is no twist, there is no constriction at incisura angularis, everything is okay. But still we have intractable GERD. Maybe that was due to migration of a sleeve, or so yes, you have reduced, you did chloroplasty. Can just, our now target is low pressure, because sleeve is high pressure. Just we add the loop, we can add to, yes, because BMI is low, we cannot go from ilium, just from this DJ or Trett's ligament, we go 100, 120, and that will be not SASI, like SASI, that is enterojejunostomy, and this will be low pressure. Are you agree in such a situation? Have you any experience?
You mean jejunostomy to be performed?
No, not jejunostomy. It will be enterojejunostomy.
I don't have a personal I don't have personal experience in such a case, and I'm sorry, I cannot comment on that. I've not performed that procedure. But in my case, whenever there is some, even in spite of having unobstructed sleeve, so there's no obstructions, there's no torsion, there's no twist, there's no any obstruction in the pylorus. But converting them into Roux-en-Y and mini gastric bypass has certainly helped my patients to overcome this GERD problem.
Sir, a patient, because this we have a lot of our youngsters, and this will be also a message for them. Patient is with intractable GERD, but he's a heavy smoker. What you will do in this case after a sleeve gastrectomy?
I think we need to do some counseling to those patients, because converting them into either Roux-en-Y or OAGP can again lead to some marginal ulcers in smokers. We know that. So patient, if they want to go some salvage procedure, they have to quit this practice. Otherwise, we should prepare them and their families that if they don't quit smoking, they can have some these major problems. Otherwise, the only thing I would suggest is that we can do some pyloromyotomy to open this pylorus, so that the some narrowing which is there at the pylorus, it opens up and they don't have this reflux problem. I don't think we can convert such smokers or into Roux-en-Y or mini gastric bypass procedure. This might be counterproductive sometimes because of the marginal ulcers. We know that it can cause some time perforations, which can be really lethal also sometimes.
Sir, I agree with you. So when patient is heavy smoker, if we will go and we know he will smoke, he will smoke. Personally, I am facing here in Dubai. They will smoke. They will ask you, yes, I will not smoke, but they will smoke. So now patient is suffering with GERD, and also already we did sleeve. You have not fundus for fundoplication or something like this. So are you agree for truncal vagotomy? If you remember, so when there was no PPI, and personally I remember that era, so we did lot of entrectomy, Bilrothman 2, and many surgeries, and also highly selective vagotomy. And nowadays also some well-known surgeon, they are talking about this. When patient is heavy smoker and you are going to do bariatric surgery and any type of gastrojejunostomy or gastroileostomy, then you can go for truncal vagotomy and do this.
Yeah, this is a novel idea. Yes, one can do that, but I don't know what kind of results. I don't have any published data on that. But truncal vagotomy, how much it has helped my patients. Yes, it can be helpful in some set of patients, as you rightly said. But again, we have to find out some the middle path for these patients to save them from the other complications. It can be useful.
Yeah. Sorry about teres ligament, that plication. I cannot ask plication, just wrap of that teres ligament. In this case, in this specific case, patient is so definite intractable GERD, smoker, and there was a little migration. You reduced that migration. You did chloroplasty. And my question about links and also teres ligament, so wrap. What do you think about both of these things? It will be helpful for the patient because maybe it will reduce reflux.
Some surgeons, they have been doing all these wraps, and to some extent that have helped. But still, we cannot say that it is a way out for all these patients, or this is a salvage procedure for them. Yes, one can try, and we still need more studies and datas and RCTs on this, whether these are really a salvage procedures for this kind of patients. For my personal, I have not performed this procedure, so I cannot comment much on that. But we need more data, more studies, and more cases for all this.
Yeah, definitely. Sir, regarding, so because we also earlier you have mentioned this weight regain is also after Roux-en-Y gastric bypass, and because we know, yes, this Roux-en-Y is also hypoabsorptive, but main is restrictive procedure, because that is the standard. I am talking about standard Roux-en-Y gastric bypass. Yes, now we can see longer BP limb, tailored BP limb. There are many things, but standard Roux-en-Y gastric bypass, that is more restrictive as compared to hypoabsorptive or malabsorptive. If you face such a situation, what you prefer? Are you prefer distalization? Are you what you will do? Or you will go for endoscopic? Definite. You will go for MDT. You will go for that medicine. Then are you also prefer to go? Maybe there is a little pouch dilated, gastrojejunostomy dilated, role of endoscopy. I am interested to hear more about this situation.
Uh, in my practice, when there's weight regain or plateau in case of Roux-en-Y gastric bypass, the distalization has been of some help to the patients, not all set of patients, but distalization would be my first preference. The size of the stomach in Roux-en-Y gastric bypass, the size of the stomach is already small, very small, and the size of gastro J is also very small. If we see, if we compare Roux-en-Y gastric bypass with OAGB, we know that the size of stomach in OAGB is much, much longer, much larger, more volume of the stomach, and the size of stoma is also large. So reducing the size of stoma or reducing the size of stomach, to my knowledge, may not be that helpful. But yes, but distalization can be of help because you are adding more malabsorption initially to a primary more restrictive procedure. You are outbalancing now with a dose of high malabsorption. So I would suggest doing distalization can be of some help to these patients.
Yeah, thank you, sir. Sir, again, we must also highlight, so this common channel is very important then when we are going to do distalization, because we cannot maybe go for standard that Sugarman theory. So, but maybe we must save at least 300, 350 common channel. That is the most important, because especially in this area where we are living, unfortunately, patient are not follow properly and then maybe face more micronutrient deficiency or malnutrition.
Yes, Dr. Abbas, I think a common channel, whether you are doing any kind of bypass procedure, I would suggest that minimum 300 centimeters should be left behind, because anything less than that we have seen so many nutritional deficiencies, macro as well as micro occurring. So now we have enough published data on this, many RCTs done on this, that minimum 3 meters of common channel should be left behind after any kind of bypass procedure. Yes, I agree with you.
Sir, regarding this, if you are going to do distalization or any type of revisional surgery, especially you are going to do this sleeve to Roux-en-Y or sleeve to OAGB, it's your routine practice to measure whole length of small bowel.
Yes, Dr. Abbas, not in primary surgery, but in revision surgeries, we measure whole length of this small bowel. The reason being a limited bypass or a standard doing bypass, like doing 150 centimeters from sleeve to mini gastric bypass or AGP, may not be sufficient. So as a rule in my practice, when I'm converting sleeve into OEGB, MGB, I always do bypass of nothing less than 225 centimeters. We have even gone up to 300 centimeters in very high super obese patients. So, and measuring the length of bowel means that you should be very clear that you are leaving at least 3 meters of distal ileum behind, so as to avoid any major macro and micro deficiencies in your patients. That is a must that one should avoid. And if perchance the small bowel is it's a short bowel or less, length is less, you should be conservative in doing your bypass. You should be very particular. You leave about 3 meters of your intestine behind in the common channel.
Sir, thank you. Sir, another issue that not routinely, but we face is the marginal ulcer. And you did a Roux-en-Y gastric bypass, and I am interested if you have faced such a situation or not till this time, because you have decades experience of bariatric surgery. So patient is suffering with marginal ulcer after Roux-en-Y gastric bypass. Patient is not smoker. Patient, okay. Sometimes, yes, most commonly we face such a situation in smokers. You can imagine smoker or not smoker. That is not my main topic. So my topic is intractable marginal ulcer after Roux-en-Y gastric bypass, not response to anything. Anything mean PPI, medicine. So you did also change MDT, use of MDT, diet, but still patient is suffering with marginal ulcer. And also endoscopically confirmed, yes, this is marginal ulcer. So that was maybe that was H. pylori, you eradicate H. pylori, everything you did, but patient is suffering. Have you faced such a situation? First, my question.
No, I have not faced that particular situation, but yes, I've seen people discussing in the conferences about all these procedure. So I think for the best thing is to undo the procedure or the reverse the procedure. Like if you have performed some, if the marginal ulcer has leaked, you have to take down the gastro-J or do the fresh gastro-J. If it is patient is only symptomatic and it's not responding to any kind of treatment as you are saying, then I think reversing the procedure can help, like doing gastric anastomosis back and taking down the gastro J and restoring the anatomy back is the only, I think, way out for these patients if they are fail to respond to any kind of medical or other behavioral therapies.
And in such a situation, also you will prefer to do a wide sleeve.
Wider sleeve from RYGB?
Same case.
RYGB?
So yeah, same case. Okay. So when you reverse to normal anatomy, okay, you will do gastrotomy, and also uh, everything normal. So because there is still we have stomach remnant fundus, or you remove that area. So for because patient has no reflux, patient was suffering with marginal ulcer. So also we can go for a wide sleeve, and
Yes,
that's my question.
yes, we can do, but again, we don't have enough data that it's really going to help the patient in weight loss because having dilated sleeves, maybe their chances of weight regain are much more than the other ideal sleeves. Yes, for time being, because you're again reducing some acid content in the stomach, you can take out the rest of the uh, stomach, like the along the greater curvature or the fundus of the stomach. That might be of some help, but still not able to comment whether this is a really best suited for the patient. One can try, and but still we don't have enough data to support that how many patients would respond well to this procedure. But converting from Roux-en-Y to sleeve is again not a simple thing. It's again a very challenging thing for the surgeon as well as for the patient to be at that procedure. So it all depends upon the personal choice.
Sir, can we give the chance of truncal vagotomy in such a case? So, because if we go for complete,
Yes. Yes.
we can go for,
Truncal vagotomy, yes. Yes, truncal vagotomy might help this patient.
yeah. Sir, same patient, like Roux-en-Y gastric bypass, but patient is suffering with reflux, acid reflux. There is a hiatus failure, maybe some migration of this pouch. So what you will do? Just I will, if I ask question, can we go for fundoplication because we have remnant fundus after reduction of this pouch and repairing the hiatus? Are you agree to do some fundoplication in this situation?
You mean the after Roux-en-Y gastric
After
bypass
Roux-en-Y, after
or
Roux-en-Y gastric
even in case of
bypass, patient is suffering with reflux. There is also some migration of pouch because we have remnant stomach.
yes, we can do as to this might be of some help to the patient because ultimately the goal is that the OG junction should not be moving back into the thorax. So it can be having some traction on that. Maybe it can help the patient doing some wrap on that. Yes, it can be of some help.
It will be. Sorry, patient with mini gastric bypass, because as you know better than me, so if we see the data, so regarding, because we are talking about marginal ulcer after gastric bypass, if we compare, this is more common in Roux-en-Y gastric bypass as compared to mini gastric bypass. Still we see the pouch of mini gastric bypass is larger, more acid production, But due to buffering effect of bile, we face less marginal ulcer in OAGB. That is the now data. So not only I am asking or someone, this is the data. But
Yes.
again, patient is suffering with marginal ulcer, and also routinely this ulcer is at the site of intestine, at the site of jejunum. So no response to medicine. So have you faced such a situation? Because you are, I know, I also following your as well as your papers and especially regarding MGB. Have you faced such a situation? And you did a surgical intervention. If you select, you must go for Roux-en-Y, you must go for brown anastomosis, go for, I don't know, for vagal, this truncal vagotomy, 3, 4 options.
Yes, you're right. I have faced in a few of my patients, and sometimes doing this bronze anastomosis is advocated. Sometimes you have to do some Roux-en-Y reconstruction for this patient. Uh, this Dr. Ruiz diverted MGB is also helpful in these patients. So these are some salvage procedures when there's intractable marginal ulcer which is not responding to any kind of treatment. This might help the patient.
But sir, but when Rui is doing, because Rui is doing for reflux, and also
Yes.
personally I interview him, he'll discuss about this his procedure, because we are talking no marginal ulcer. The base of marginal ulcer is acid, not here. And when we
Yes.
will do that, definitely there will be more marginal ulcer, because still this we will take the buffering effect of bile from that patient. And overall, this is a Rui procedure. I have talked personally with him, because this will be then Roux-en-Y with a big pouch, more acid production. There is more chance of marginal ulcer. Are you agree?
Yes, they can be because bile is always an alkaline in nature and it is neutralizing the effect of acid. Yeah, we all know that. And that is the reason that in mini gastric bypass, the chances of marginal ulcer are far less than RYGB. So we should be doing something which is neutralizing the effect of acid. The main thing is that we should reduce this acid secretion, which can be of some help to the patients.
Sir, just my suggestion. So, because I know you have a lot of patients and you are someone, so people follow you, there is no doubt. So, can we work on truncal vagotomy? So, in future, maybe this will be also a standard, because nowadays the one of the main issue is marginal ulcer. There is no doubt. And due to this, in Roux-en-Y gastric bypass, we face two main situations: marginal ulcer and internal hernia. These are two really nightmares. There is no upper, because personally I faced such a situation. Perforation
Yes.
I faced after Roux-en-Y gastric bypass. Patient come here 3 midnight with generalized peritonitis and septic shock. I faced such a situation personally in my cases. So now, so can we go, maybe in future this will be a standard technique when you are going to do any type of gastroenterostomy, gastrojejunostomy, gastroileostomy. There is, because chance of marginal ulcer, this is the standard, go for truncal vagotomy. If you can do so, then it's simple within 5.
Yes, you're right.
Sir,
Yes, it can reduce the acid secretion by doing simple vagotomy. One, yes, as you suggest that we should be performing truncal vagotomies in patients in which the chances of marginal ulcer we see much more. Yes, it can be routine. Yes,
one of our colleague has
can be.
question about shorter gastric pouch in OAGB for the reduction of marginal ulcer, but there this is no chance, because if you will go in with shorter pouch, there will be more bile reflux. Bile will be more in esophagus. So
So that is not an OIGP.
that will be a
Having said that,
disaster. That will be a disaster. So we must go for maximum longer and narrow pouch, and we must think about marginal ulcer. So one of the, in my opinion, in marginal ulcer, so we can go for truncal vagotomy. And also I have talked a lot with Helmut Billy. He's doing this, because I am now highlighting his name. by name because he's doing and he's working on this, and especially in smokers. If patient is smoker, so you can go for any type of gastrojejunostomy. So yes, must do truncal vagotomy, and now he's working on his lot of patients, and hope we will soon see his data. And in my opinion, this will be a very helpful, especially for those who are smokers. Then they can also enjoy such a surgeries.
Yes, sounds good.
Yeah, because he's working on this. Sir, regarding mini bypass, so because also you are doing routine mini gastric bypass, have you faced severe malnutrition after mini bypass, and what you did in those specific cases?
Yes, very important. For the surgeons who want to perform mini gastric bypass, you should know that this is a highly malabsorptive procedure, and one should be very careful. You have to be very selective when you are performing OAGB, MGB. One set of patients may behave different with some BP limb length, and other set may behave very different. So you have to be study your patient well. And the question is, did I face some news? Yes, in one of a few of my patients in the initial years when we started doing MGB or IGB, when there was not enough published data on the BP limb length, how much bypass to be done. So we were not considering the age of the patient. If the BMI was more, we were doing a longer bypass. If the BMI was less, we were doing shorter bypasses. And ultimately, in few of the middle-aged people, when the bypass was length was crossed, more than 250 centimeters, some 275 centimeters were done. And those patients did not tolerate that dose of malabsorption, and they had some severe nutritional problems. In my published data of 457 of MGB cases, where we have 16 or 17 cases which we had severe nutritional deficiencies, we could correct those nutrient deficiencies with some intensive nutritional support with the help of my dietitians. But about two or three patients, we really had to convert. One patient, I had to shorten the length of bypass so that the malabsorption could be reduced. In two patients, we simply had to reverse the procedure to a normal anatomy. We had to do the gastrogastric anastomosis, bring down the gastro J. And if you tell you the best procedure of this severe nutritional deficiencies, the indications to bring them to normal anatomy is when the low albumin level, they do not improve in spite of the best medical or the nutritional support the team is giving, and the levels of albumin are less than 2 persistently for about more than a week or month or so, one should think of reversing it. Or if you see the signs of development of ascites is going to happen, it means the patient has failed to respond to any kind of treatment. One should undo these procedures and convert back into the normal. Now, as a rule in my practice, we have very good criteria of age. So with the growing age, we are very conservative in doing the BP limb lengths to the Asian or the Indian population in my studies. So if the age group is about 40 years, we have a standard bypass length of about 160 centimeters added BMI to it. So for example, if the patient is 40 BMI, the age is 40 years, I would do the bypass of 160 plus 40, that is 200 centimeters. Now, if the patient is of 60 years of age, we would reduce the length standard bypass to 130 centimeters. That means a patient of 40 BMI in 60 years of age, I would do 130 plus 40, that is 170 centimeters of bypass. And that has brought down our nutritional problems to very, very less. And we are happy with this by reducing this BP limb length in advancing age group. And that is really helping us. Because the younger age group, they can easily tolerate this strong dose of malabsorption as compared to the senior age group. Now, the bypass length is, we are very conservative and we decide as per the stats of the patient, then we do the bypass.
Sir, excellent, excellent. And regarding this, because I am also interested to hear from your side how you prepare such a case with malnutrition, and then you will go for surgical intervention. Or you prefer to go first any type of feeding tube in remnant stomach with the guide of ultrasound, or some person they are doing this, and they put this like pigtail something there, and then they feed the patient, prepare the patient, because then they will go. Are you agree in such, or no, you will go for TPN?
Uh, uh, if the patient is not fit for surgery, very sick patient, ideally, yes, we should go for all these feeding gastotomies of the patient. And if the patient is really sick and you would want to intervene very early, yes, TPN should be done, and you should try to undo the procedure as soon as possible. The two cases of my own series which I reversed, uh, I did them immediately without doing any feeding gastrotomy, and those patients did well. Few of the patients from other centers which came to us for this reversal, again, feeding gastrotomy was not done. Only after some parenteral nutrition, we could undo the procedure, and again, those patients responded well to the treatment. Because we do not want to waste further time. Sometimes patient would not respond because the sick patients, they need to be uh, undone immediately.
Yeah, thank you, sir. Sir, now a patient, so again, I'm asking about weight regain after sleeve gastrectomy. This is not insufficient weight loss. This is weight regain. 3 year, 4 year, 5 year, okay, everything was fine. Now patient back, that was standard sleeve gastrectomy. There is no GERD. Patient is weight, so this weight regain, but patient is again heavy smoker, unfortunately smoker. So we have two option. So we can go for sadi, that will be duodeno or duodeno, and we can go for oagb. Have you any experience of sadi in these cases?
Dr. Bas, no, I have not done study in my series. Yes, I have converted sleeve to AGB for the weight regain. So, but those patients did not have any this problem of smoking or the marginal ulcers, and those patients adding an element of malabsorption to the restriction has really helped my patients. Of course, even in those cases, re-sleeve was also done. Not only the malabsorption was added, but also the re-sleeving was also done. So the sleeve size was reduced. Again, the element of restriction was increased, and the element of malabsorption was added. And those patients again they responded, and they had a good amount of weight loss after the procedure.
Sir, yes, this is, he is not smoker, as you have mentioned. And also you resize that pouch, a standard pouch, and you are going to do OAGB. So my question, are you measure whole length? And in this case, what is your standard? What will be your BP limit? What will be your common channel?
Nothing less than 200 centimeters minimum when doing this revision surgery. Depending upon the age of the patient, age is less than 40 years, I would even go up to 250 centimeters for these patients, because conservative bypass of 150 centimeters in those patients may not be very helpful.
Okay,
So
but
I would also make a whole length of course, the whole length of bowel has to be measured, because you are doing a longer bypass. You ensure that there is a common channel of about more than 3 meters.
because, sir, personally, I measure till 10 meter, 8 meter, 7 meter. That is the routine. 8, 7 meter is routine because I measure when I was young. So hundreds of cases I measure. So ball length, because I am follower of Professor Carbaho, and routinely he measure whole length. But definitely I was measuring. But this was average 7 meter, 8 meter. So if ball length is 8 meter, again, you will not go ahead to 250, maximum 250, this BP length.
Again, depends upon the eating habits of the patients and the subset of patients you are dealing with. I've performed this longer bypass length in Caucasian population, and even I have done up to 300 centimeters. They have done well. In some set of patients, uh, again, the chances of nutritional concerns are there, especially in Indian population. So we are very conservative in my cohort of patients. I do not go beyond 250 centimeters in this case, in spite of there is even 8 meters of intestine may be there, but I don't cross that limit.
Because one of our colleague, Dr. Adil Bangash, his question is about this, and especially in Asian people. So if we measure from ileocecal and we measure 400 centimeter, it means we have saved 400 centimeter common channel and we bypass remaining. But no, you will go from DJ, you will measure the whole length, but routinely you measure from DJ and 250 maximum. This is your standard as I understand.
Yes, yes, 250 for the revision surgeries.
Sir, really so much thanks. Really appreciable. You are always helping, you are always sportive and definite. And we will go ahead with this interview series, and after June, July, we will go for complication, and again we will disturb you. We need your support. And sir, we are going to do this GLR ebook. That is amazing thing. That is tips and tricks with the help of a Malaysian company. And now we have started to uploading our videos, and many bariatric surgeon were known already they upload. So we invited you as an author of that book. I will share with you the detail of this GLR ebook, how you can upload your videos. This is only tips and tricks. So then we can see if someone want to see tips and tricks of Professor Jammu, tips and tricks of MGB, tips and tricks of so that revisional surgery different. You can upload any video, short text, some these pictures and short video, and also this will be available as an app in mobile and access. So it will be honor, sir. Sir, any message for our youngsters who are just now going to start?
It was my honor, Dr. Abbas, to be with you, and it was very fruitful discussion with you as always. You are a genius in your own self, and it was learning from you as well. Thank you so much. And the message to all the viewers and the youngsters, yes, but bariatric surgery is a really good field to enter in. It's very challenging field, and you should always have your mentors when you start doing these surgeries. This is such a surgery which we have to learn all our life. This is not that you will go and attend a conference and you start doing procedure. Even sleeve we are learning today, even in MGB we are learning today, even RYGB we are learning today. So there are so many exit strategies. It's all learning and learning all the way. Thank you so much.
Sir, so much thanks, and my viewers, so much thanks. These programs, these interviews is due to your interest. If you have any question, you can ask in comments. And next week, Tuesday, 10 p.m., we will be with Professor Mario Mozella. He's from Italy, and he's also well-known bariatric surgeon and expert in revisional bariatric surgery. So much thanks, sir. Again, so much thanks, and hope to see you soon in any international conference.
Sure.
Thank you, sir. Thank you, sir. Have a nice time, sir. Thank you, sir.